Hi, my name is Connie Koklanis and you're watching the video titled Diplopia. In this video, we'll be discussing how to go about assessing a patient who is complaining of double vision and also how to interpret what's called the diplopia chart, which is utilised in the assessment of a patient with double vision. Okay, before we proceed to discussing the assessment of a patient with double vision, I'd like us to revisit the principles of diplopia and recall that when a patient is experiencing double vision, that the direction of the diplopic image will always be opposite to the direction of the deviating eye. This will become important in interpreting the patient's complaint of double vision and also interpreting the diplopia chart. So recall, if you have a horizontal deviation, an esotropia will cause uncrossed diplopia, the exotropia will cause cross diplopia, and where we have vertical deviations, if the eye is up, the image will be down, and if the eye is down, the image will be up. Now, we haven't discussed torsion very much in previous subjects, but the same rules apply here in relation to the diplopic image. If the eye is excyclorotated or there's an excyclotropia, then the image will be the opposite, it will be intorted. And again, if the patient has encyclotropia, the image will be extorted. Okay, now the first thing we want to do if a patient is complaining of double vision is take a thorough history that is questioning that double vision. And the first thing you want to know is it monocular or binocular? So if you simply ask the question of whether the second image disappears when they close one of the eyes, then you've got confirmation there that it is binocular, and then we are in the right domain to start questioning strabismus as the cause of the double vision. If it's monocular, so it persists when either the right or the left eye is open, or closed I should say, then the investigation will be quite different as to what is causing the diplopia in that instance. The other thing you want to make sure is whether you have definitely diplopia, whether there's blur. Patients who have blurry vision sometimes articulate it as though it is diplopia because of the shadowing that the blur creates. So just be clear that the patient does see two images. And sometimes if you actually ask him to look between the two images, you can actually see them make a saccade from image 1 to image 2, which gives you that indication that, yep, definitely they're seeing two images here. Okay, ask questions around the onset and the frequency. When did the double vision first start? How frequent is it? Is it present in certain positions of gaze? The sorts of questions that will give you that little bit more information about the double vision and its features. Okay, now we want to know whether the double vision that the patient has, whether it's an indicator that the patient has a horizontal deviation or vertical deviation. Now, the way in which we do this is by asking questions about where the second image is placed. So should the images be side by side, we know there's some horizontal component to the deviation. And if there's a vertical misalignment between the two images, or they're vertically displaced, then there's a vertical deviation present. The other question we want to ask is if the line is tilted, the second image is tilted, in which case you've got also torsion present. Also ask the patient if there's any particular positions of gaze where the diplopia is worse. And we'll see in a moment as we talk about interpreting diplopia charts that the position where the diplopia is worst is of quite a lot of interest in your interpretation of the diplopia chart. So see if they have noted or have noticed that there is a particular position, say for instance in right gaze, that the double vision is definitely worse and they avoid that position, for instance. Okay, so what we see here to the right is what is known as the diplopia chart, and we can see that it's been plotted here. And what a diplopia chart is it provides a record of the separation of the double or the diplopic images in the 9 positions of gaze. And the way in which the diplopia chart assists us is that it assists us in determining the direction of gaze where the diplopia is worst, which is important when we're trying to make a diagnosis of a patient's condition, and also assists us in determining which is the primary affected muscle. How do we go about plotting the diplopia in 9 positions of gaze? In plotting a diplopia chart, the patient wears red-green goggles. Now, they don't have to wear red-green goggles, but it does make it easier for the patient and for the examiner in terms of working out which image belongs to which eye. Now, what the examiner does is you'll shine a light in front of the patient at approximately 50 centimetres. So if you remember the Hess charts completed at 50 centimetres, so you would do so similarly with the diplopia assessment. And you would start off in primary position, ask the patient where the two images are in relation to one another, and you plot this on your particular chart. Now, what you want to ask the patient is about where they are in relation to one another. So is it horizontally displaced, is it vertically displaced, and is there a tilt of the image? And because the patient is wearing red-green goggles, they can tell you where the red one is in relation to the green one. And you, the orthoptist, can actually tell which image belongs to which eye. Okay, now in terms of tilt, you won't be able to ask the question about tilt unless you're using a linear light. So if you use a spotlight, you won't have the information regarding the torsion. Once you've established the diplopia in prime position, then you progress to the other positions of gaze. And as you move through each position of gaze, what you're interested in finding out is whether the images are closer or further away than they were in the previous position. So you're trying to gauge, is it increasing or decreasing as you move around in the various positions of gaze. In terms of recording the diplopia chart, you can see here that to the right we have an example of the recording of the diplopia chart. Now, what you can do is you can ask the patient to estimate the separation of the images. And in this instance, if you have a look in direct elevation, the images are 3 centimetres apart, as opposed to in dextro elevation, they're 4 centimetres apart. Now, you don't have to have this on the diplopia chart. You could simply draw what the patient is explaining to you, which is that the diplopic images increase in separation as a patient moves from direct elevation to dextro elevation. Okay, now always record which line belongs to which eye so that you can then make the interpretation as to what sort of diplopia you have, crossed, uncrossed, etc. And always remember to label which is the right-hand side and which is the left-hand side. Now, classically, when drawing a diplopia chart, it is from the patient's perspective, so the right will be on the patient's right-hand side. Okay, so how do we go about actually interpreting the findings? Well, the diplopia chart, a bit like the Wilczewski head tilt test, can actually give us information about which is the primarily affected muscle. And it's actually a two-step process in this instance. The first step is find the position of gaze where the separation is worst in terms of the diplopic images. This is where the deviation is worst. Clearly, where the images are most separated is where the eyes are most deviated. So if we look at the example here, the greatest separation occurs in dextro elevation. And so the next thing we need to think about is which two muscles are utilised in dextro elevation. And this is the right superior rectus and the left inferior oblique. Now, the next thing we need to consider is the rule that the most distal image, so the image that's furthest away, belongs to the paralytic eye or the affected eye. So if we look at, again, dextro elevation, here is the red image, which belongs to the right eye, and here is the green image that belongs to the left eye. The left eye image is the most distal, so the left eye is the affected eye. Now, we only had two muscles we were considering at this point, the right superior rectus and the left inferior oblique. So in this instance, the diplopia chart is telling us that the left inferior oblique is the likely affected muscle. Now, again, as I've indicated in other videos, you would never diagnose a patient off one clinical assessment, but this would support your diagnosis of a left inferior oblique if your other investigations are pointing you in this direction as well. Okay, now that we've established that we think it's a left inferior oblique palsy, the next step is to consider, do the images that we see here, or does the diplopia that we've plotted, is it consistent with what we expect to see of a left inferior oblique palsy? Now, to work this out, we need to consider what deviation the left inferior oblique palsy would cause. So the left inferior oblique, let's start off with the horizontal, I should say. So if we start off with the horizontal, the left inferior oblique, it is a abductor. So generally in most instances, it'll cause an ESO deviation, which means we should have uncrossed diplopia. And what we can see here is the green image always remains on the left side, and so we have uncrossed diplopia. Okay, so tick on the horizontal, it is consistent with a left inferior oblique palsy. Let's think about the height. The left inferior oblique is an elevator, which means it'll cause the left eye to be hypodeviated or to have a hypotropia, which means that the image will be up. So the left image should be higher than the right image. And again, if we look at our diplopia chart consistently, the left image is higher than the right image. Okay, finally we need to consider the tilt. Now, I'm not going to talk about the tilt in this video too much because we have a video dedicated coming up shortly on torsion specifically. But in terms of torsion, the left inferior oblique will cause an encyclorotated eye, so it will cause an extorted image. And I can tell you at this point that this is demonstrating an extorted image, but again, we'll come back to this in a separate video. Okay, so this diplopia chart is indicating to us, because the greatest separation is in dextral elevation and because the most distal image belongs to the left eye, this is likely to be a left inferior oblique palsy, and the diplopia the patient's experiencing, which is uncrossed, we have a vertical deviation that reflects a left hypo, and we have an extorted image, which reflects an encyclorotated eye, is also supporting this left inferior oblique palsy. Okay, one other point I want to make before we move on is that when we talk about finding the position where the images are most separated or where they're worst, we're talking about the horizontal and the vertical deviation. And this will be worst when you move the patient into the field of gaze where the affected muscle works. Okay, this, however, does not apply to torsion. Torsion is worst in the opposite direction. And the reason is that if you go back to binocular vision and refraction, or to the bridging program where you learnt about the actions of the extraocular muscles, we talk about primary actions and secondary actions of the muscles. And the primary action, if you recall, is when the visual axis and the muscle plane coincide. And the secondary action occurs when they are 90 degrees to one another. And the secondary actions of the inferior oblique is or includes the torsion element. So this is when we would see greater amount of torsion. And so if we have a look at this example, we see that in the field of action here, the torsion is not as great as it is in this position here, which is in abduction. So the primary action occurs in adduction, and here we see the greatest amount of separation between the vertical images, or the greatest vertical separation between the two images. But when we pop the patient into abduction, we see the greater amount of torsion. So just bear that in mind when you're looking at diplopia charts. You will usually see the torsion be greater in the opposite direction to where the separation occurs in terms of vertical and horizontal separation. Okay, let's go through one more time looking at the image and the corresponding deviation. Now, the first image I've given you here is exactly the same as what we just discussed. So just pointing out again, we have an uncrossed image, so we have an ESO deviation. We've got a higher image, so we have a hypo deviation, and we have an extorted image, in which case we've got an encyclorotated eye. Let's do one we haven't seen before. Okay, in this instance, we've got a horizontal and vertical deviation in primary, and we've got single vision in elevation. Okay, the image is uncrossed again. The left eye image is always staying on the left side, so we have uncrossed diplopia. The left image is lower, so we have a hyperdeviation. And the image is intorted in this instance. As we can see, it's tilted in the opposite direction to image A. And so in this instance, we have an excyclotropia. Let's move on to some examples where we diagnose what the potentially affected muscle is. Now, in this instance, we can see we're using vertical lines rather than horizontal lines to depict the double vision, and you can use vertical lines rather than horizontal. I actually use vertical lines when I plot a diplopia chart, and I actually think that this is more conventional or more commonly used. However, you can use horizontal lines if that's something that you utilise. It's probably best to be consistent with whatever approach you elect to utilise. So in this example, we see that we have horizontally displaced images. There is no vertical misalignment between the two images. Now, the green line happens to be longer, which might be creating the illusion that there's something vertical there, but it isn't. We purely have something horizontal. And what we can see here is that the horizontal deviation is worst in right gaze. Okay, so in this position in right gaze, we have two extraocular muscles that are acting, the right lateral rectus and the left medial rectus. So the next question we would ask is, which is the most distal image? It is the right eye that is the most distal image. So it is a right lateral rectus that we see here. The next thing to consider is, does the diplopia match the deviation? So if it's a right lateral rectus palsy, the right lateral rectus is an abductor, which means it is going to cause an esodiviation, which means we should have uncrossed diplopia, and indeed we have the right image remaining on the right side. Okay, so in conclusion, it looks like we have a right lateral rectus palsy here. Okay, another example. Where's the greatest amount of separation? We can see that it's here in lavodepression. We think about which two extraocular muscles are utilised in lavodepression. It is the left inferior rectus and the right superior oblique. Which image is the most distal? It is the left eye image that's the most distal. So here we have a left inferior rectus palsy. Okay, let's think about the image. Is it consistent with what we expect of a left inferior rectus palsy? Okay, horizontal first. The inferior rectus is an adductor, so we would expect most likely an exodeviation and cross diplopia. And what do we have? Yep, the left image here has crossed over to the right side. Okay, vertical. A left inferior rectus is a depressor, so it would cause a hyperdeviation, and the image would be down. And again, this is what we see. The left image is lower than the right image. Okay. And lastly, torsion. The inferior rectus causes a encyclotropia, which means we'll have an extort image, which is what we see here. So it looks like this is a left inferior rectus palsy. Okay, one more example here. Now, in this particular instance, we've got single vision across right and left gaze and in primary position. We have a vertical deviation in elevation here and a vertical deviation in depression here. And we see here purely vertical displacement, no horizontal displacement. Now, if we had to make a call on where the deviation is greatest or where the separation is greatest, it looks like it's in elevation. There's more separation there certainly than there is in depression. And the most distal image belongs to the right eye. So it looks like the right image is the affected, the right eye is the affected eye. But this does look unusual. It's not usual that you'll have single vision in primary right and left gaze and diplopia in up and down gaze. This doesn't look very neurogenic. We're getting diplopia across the entire elevation and across entire depression. There's no horizontal displacement. There's no torsion. So let's look a little bit deeper. What does the double vision look like in down gaze? Well, it's actually reversed. If you look here, the right image is above the left image, and here the left image is above the right image. Reversal of height is a classic mechanical restriction, or a finding that we see in mechanical restrictions. And so here we have a right mechanical restriction. Again, your previous investigations would have been leading you to the diagnosis of a mechanical restriction, and this investigation would support that finding. Okay, let's come back finally to Miss Jones. Miss Jones had a diplopia chart performed on her, and here is her findings. Okay, what do we see here? Greatest separation is in LAVO depression. The most distal image is that of the right eyes. And so we're looking here potentially at a right superior oblique palsy. And in terms of images, whether they're displaced appropriately or consistently as we would expect for a right superior oblique palsy, well, we would expect the superior oblique to cause an ESO, so it should be uncrossed, and yes, it's uncrossed. The left superior oblique would cause the image to be down because of the hyper deviation it causes, and yes, the right image is down. And a right superior oblique palsy would cause an intorted image to be seen, and here we indeed have an intorted image. Okay, so in summary, there's a couple of golden rules to remember when looking at diplopia charts or when assessing a patient with diplopia. Generally, the position in which the separation of those two images is greatest is the field of gaze where the paretic muscle works. Okay? And then the most distal image belongs to the affected eye. If you recall those two rules, you'll be able to come to a diagnosis or a potential diagnosis for the patient. Now, in terms of images, you need to always remember the position of the images will be opposite to the deviation, and what you want to make sure of is when you've identified what you think is the affected muscle, to ensure that the diplopia the patient is experiencing is consistent with that. And just remember that torsion behaves differently in the sense that torsion will be greatest in the position where the secondary action of the vertical muscle takes place. Okay, that brings us to the conclusion of this video. Thank you for watching.